which gives those living with arthritis a voice to share their experiences. You can contribute to scientific research by simply completing the quick insights assessment online and sharing your experience of living with arthritis at arthritis.org/insights. I just got another assessment online assessment the other day. The data from the Insight study shows 100% of respondents reported pain, and 94% of respondents in Florida reported pain interfering with day to day activities. The data from this study also helps us determine what educational programs are needed locally, just like the one we're hosting this evening. In response to the persistent chronic pain reported by patients in this study, the Arthritis Foundation is excited to announce the Vim App, a new way to combat chronic pain. With the new app, you can set achievable goals, manage your chronic pain, and get encouragement from others within our arthritis community. The app is now available on Google Play and in the Apple App Store. Search Vim Arthritis or Vim Pain to find the tool. You can also visit arthritis.org/pain to learn more about the app and other Arthritis Foundation pain management tools and resources. We were going to have Stephanie Remsen with us this evening, but unfortunately, she's had a family emergency. So I'm going to share with you a little bit about my journey of being a woman living and thriving with arthritis. I had my first flare of rheumatoid arthritis in 1973 when I was a freshman in college. And if you do the math, this May it will be 49 years that I believe I have lived successfully with RA. It's a mean monster to fight, but thanks to great medicine, the Arthritis Foundation, and prayers and support, I've been very lucky. What's important to me is, in spite of being told when I was diagnosed that I would be crippled in 10 years, I should not have kids or get married. And after being prescribed 16 full strength aspirin a day and 14 hours of rest a day, I've beat the odds, as I imagine all of you have also done. In 73, they just didn't know or have the tools we have today. I ended up getting married. I hate to say twice, but twice. And so it didn't prevent me from falling in love. I moved with my first husband to Spain, where we lived for 2 years. Then I've lived in St. Louis and then come back to Orlando. And I have, according to Social Security, worked every year since 1973, only taking short-term disabilities for 4 surgeries. And I'm proud of that. I also was able to have a child. My pregnancy was rough. My arthritis didn't go away like it does for most women, but I still had a wonderful pregnancy and a beautiful son. I think you saw a picture at the beginning of this. He's 30. I became a single mom when he was 5. So not only was I working full time and managing RA, I was a single mom for the last 30 years. It's been an exciting road. I decided after my first or second year with arthritis, which was definitely depressing in college, that I wasn't going to let it run my life. I was going to run arthritis. And it's been a wonderful road. I've had all the horrible pain you can imagine and you've experienced, the fatigue, the depression, all the ups and downs. but I can say honestly, it's mostly been up. It hasn't kept me from traveling. My son and I have been able to go to 19 baseball parks, Major League Baseball parks in 19 different cities around the United States and Canada. And in the last probably 7 years, I've been to Europe twice, Alaska. I'm just not letting it stop me, RA stop me. In fact, I got on a plane to Europe with a flare so bad that, well, I won't go into details, but it was horrible, and took wheelchairs, in the airport. But I knew my flares. I knew they lasted 3 days and that I'd come out of it. And I did. I just retired. That's my big news. January 14th. Um, After many different jobs, 23 years at AT&T, I finished my career at a magazine publishing company as a technical project manager, and it has just been great. So I like to consider myself hope that you can manage home, you can manage arthritis, you can manage marriage, you can manage raising kids. It's not easy. I'll never pretend it was easy. I never would have survived without friends and family supporting me all along the way. But I just started a new drug because I wanted to get off of my old one because of COVID. I'm feeling good on the new drug. I get an infusion this Monday. And so I plan my life around the infusions. But I am feeling really good and happy about this next chapter in my life. So, enough about that. Uh, Enough about me. Living your best life as a woman with arthritis means managing pain, fatigue, and all that comes with chronic illness while still keeping all the balls of life in the air as well. There are a couple of areas that are important in considering all we're dealing with. Diet and nutrition. While there's no miracle diet for arthritis, many foods can help fight inflammation and improve joint pain and other symptoms. For starters, a diet rich in whole foods, including fruits, vegetables, fish, nuts, and beans, but not low processed foods and saturated fat, is not only a great for overall health, but can also manage disease activity. Whether you're trying to lose weight to reduce pressure on your joints or wondering which supplements and nutrient rich foods can help ease arthritis pain, a registered dietitian can offer personalized guidance that also appeals to your taste buds. While you may not view arthritis as a diet related condition, the reality is what you eat impacts your joints. I learned the hard way licking the brownie mix bowl when making brownies. I'm guaranteed to have a flare the next day. Exercise and activity. Exercise is crucial for people with arthritis. It increases strength and flexibility, reduces joint pain, and helps combat fatigue. Of course, when stiff and painful joints are already bogging you down, the thought of walking around the block or swimming a few laps might seem overwhelming. You can start little, even if it's sitting down and doing some stretches. I encourage you to check out the Your Exercise Solution provided complimentary from the Arthritis Foundation. Your Exercise Solution, yes, is a resource to help you create a physical activity routine based on your specific needs and ability level, with modifications developed and approved by physical therapists. Check it out on the arthritis.org website or in the App Store. Emotional well being. This is a biggie. Managing your mental health is a fundamental part of managing arthritis. Emotions that come along with the pain, fatigue, and other physical symptoms of arthritis can be surprising and even overwhelming. It's natural and understandable to experience an ebb and flow of resilience and anxiety. Your life stage, self image, relationships, responsibilities, economic security, and disease status can affect your emotions as you manage your disease. Do what you can to keep negative emotions at bay through physical and emotional self care. Some self care options include mind body practices, music and art therapy, exercise, massage, and activity pacing. Getting involved in social activities to prevent feelings of isolation and find outlets for laughter and play is also important. Also, seek professional counseling or an arthritis specific support group can give you an outlet to talk about your emotions and provide you with coping mechanisms. The Arthritis Foundation is a great resource to offer a community to feel supported as well. Pain management. Managing pain is an important piece of living and thriving with arthritis as well. Join Arthritis Warriors from around Florida on April 28th at 7 p.m. to learn their favorite tips and hacks for living your best life and managing pain. Hear tips for traveling, continuing your favorite activities, and hacks for everyday life. The lineup of speakers has been living with arthritis for a combined 105 years and are going to share their knowledge with you. Wow. I also encourage you to check out arthritis.org to learn more. You'll find articles, podcasts, and many resources on nutrition, physical activity, mental health, pain management, daily living, family and relationships, and much more. Now I'd like to introduce you to our next speaker, Dr. Maria Ventimiglia, a certified rheumatologist practicing on the East Coast of Florida. Dr. Ventimiglia.
Hi, thank you, everyone. I'm excited to be here. Thank you for joining us. So we are going to talk today about women and arthritis, and we have chose two diseases that are most commonly seen in women. The first one is going to be rheumatoid arthritis, and the next one is going to be osteoporosis. So let's start with rheumatoid arthritis. What is rheumatoid arthritis? Next. So rheumatoid arthritis is the most common autoimmune disorder that happens in about 1.3 million Americans. 75% of these patients who develop rheumatoid arthritis are going to be women. It most commonly begins between the ages of 30 and 50 years old, but it can develop at any age, right? It can even happen in kids. It can happen later in life. It is estimated that when women develop rheumatoid arthritis, they develop higher levels of pain and inflammation compared to males. Next. So why this happens more commonly in women? And there is the thought that hormones play a role in the development of this condition. There is the observation that it happens more commonly in women of childbearing age between 30 and 50, and that can be very hard because that's when we women are trying to start a life, you know, and have a career, take care of our family. So it can be very hard on us when that happens. Also, there is the observation that symptoms tend to improve during pregnancy, but they can worsen after the baby is born. And that's another reason why we think that hormones play a role in this condition. There is also some data that suggests that breastfeeding decreases the risk of developing rheumatoid arthritis in a woman's lifetime. There is also some thought that the female immune system is stronger and more reactive than men immune system. And that's why we think that it can happen more commonly in women as well. Next. So what happens, what are the symptoms of rheumatoid arthritis? Which are the red flags that should prompt you to seek medical attention and maybe consider seeing a rheumatologist? And those are going to be pain and swelling in the small joints. Usually hands and feet are the most common areas where this starts, but then it can go to any joint. Stiffness, which is very prominent in the mornings, and this can happen also in other kind of inflammatory conditions like psoriatic arthritis. And let's remember that rheumatoid arthritis is not just a disease of the joints. It can present with systemic symptoms like lack of energy, fatigue, low-grade fevers. It is estimated that women are affected differently. It affects our mobility. Women with arthritis have more difficulty than men. When they try to climb stairs, they have more difficulty standing for 20 minutes or grasping or carrying. And we have also more difficulty in our domestic life activities. Like, for example, it is estimated that 1.8 times more women than men report difficulty with activities at home. Now, once we have these symptoms of rheumatoid arthritis, how do we make a diagnosis? And what I like to say is that there is no one single test that makes a diagnosis of rheumatoid arthritis, and it's what we will call a clinical diagnosis. It's a combination of things that help the clinician and the doctor to reach a diagnosis. The first thing that your doctor will look for is they will do a physical exam. So we are going to look at your joints. We're going to look for any signs of inflammation, basically in the small joints like hands and feet. So we will want to know if those joints are warm. Are they swollen? Are they red? Are they hot to touch? If we have the suspicion that the patient may have rheumatoid arthritis, we will order laboratory tests and x-rays. In the laboratory test, we'll be looking for the presence of these antibodies, which are substances in the blood of patients that are responsible for the inflammation and causing the damage from this disease. However, not everybody shows a positive antibody in the blood, and some of you, may have experienced that. We call that seronegative rheumatoid arthritis when the patient does not have a positive antibody. It can happen in up to 20% of patients who have rheumatoid arthritis. We will also be looking for signs of high inflammation. In the x-rays, keep in mind that at the beginning of the disease, in the first few years, we may not see any x-ray findings. Those x-rays may be normal. Later on, as the disease damages the joints, it will cause what we will call erosions. Now, ideally, we want to make the diagnosis before then, right? We don't want our patients to develop erosions. So when we still have the clinical suspicion and the patient has swollen, hot, red, tender joints, we don't have an answer with the laboratory test. We do not have an answer with the x-rays. So in those cases, we will order an MRI of the joints, and that will give us a lot more information as of what is going on. How do we treat rheumatoid arthritis? Once we reach a diagnosis, and again, we want to start treatment as early as the disease is diagnosed. That is key to improve the quality of life. And as our prior speaker had said earlier, low impact exercise is very important. Exercises in the water are the best for somebody who suffers from pain. It will improve the mobility, the flexibility of the joints. Anything that can work in increasing the strength, like yoga exercises, walking, and also we want to follow a healthy diet. And regarding the healthy diet, there is, again, not magic food that will make it better, but again, choosing no processed foods, fresh vegetables, fresh fruits, and trying to stay with healthier fats like olive oil, fish oil will improve your general well-being, not just your rheumatoid arthritis pain. The next thing that your rheumatologist will probably talk to is we want to prevent that joint damage. And that's why we want to make the diagnosis really early on. So we will start our patients in what we will call a disease-modifying anti-rheumatic drug, or DMARDs. And there is a plenty of options, and there is a big gamma of treatment options. However, your doctor will talk to you about your other comorbidities. Are you a diabetic? Do you have liver disease? Do you have lung disease? All of those things are taken in consideration when we discuss or when we choose a medication for our patients. We also will want to know about your plans for pregnancy, because there are certain medications that are going to be safer to be used in pregnancy if you will need a medication and your disease does not go into remission. A lot of times the symptoms, as I had mentioned earlier, they improve during pregnancy. Next. And here I just wanted to show a picture before I start talking about my next topic. This is my kids in the Jingle Bell Run 2019. If you were not aware, the Arthritis Foundation has a 5K. This is the one in Orlando, and we love to attend. We have a lot of fun. It's very fun for the kids. We are trying to raise awareness for arthritis, and we love going. So you should check it out if you can. So next, we're going to talk a little bit about osteoporosis. And here I have a picture. In your left, you can see a normal bone. In your right, you can see a bone that has osteoporosis. And we can see a lot of holes in this bone. That's exactly what happens in the bone that has osteoporosis. Next. So what is osteoporosis? Osteoporosis, what happens is that the bone is brittle. If the bone is brittle, then it can break way more easier than a normal bone. The problem with osteoporosis, again, is that it's a silent disease. It doesn't hurt. You don't see a lump. So it can be missed in some cases. And that's why we want to raise awareness, because we want to prevent those broken bones. It is estimated that by the mid-30s, most women lose more bone or it can be replaced. If the bone is weak, then fractures can occur after minor injuries. And the most common areas are going to be the spine, the wrist, and the hip. And these fractures can lead to disability. Here in this cartoon, I wanted to show a picture of what happens in a bone with osteoporosis. So what we can see, the osteoblast is the blue guy here, and the osteoclast is the red guy. So usually in a normal bone, there is an equilibrium between bone formation and bone destruction. The osteoblast is in charge of the bone formation. The osteoclast is in charge of the bone destruction. So there is usually an equilibrium. In osteoporosis, that equilibrium is lost, is not there. So if you can see in the bottom of the slide, the red guy is getting ready there with a TNT to completely destroy that bone. And that's exactly what happens in osteoporosis. There is more bone destruction compared to bone formation, and that's what makes the bone weaker. Next. So risk factors. So again, women, we are the lucky ones. We are at a higher risk than men. And again, we do believe that hormones have something to do, and that is why it's more common after postmenopausal years. So age is a very big risk factor. It usually happens after 50 years old. It is estimated that 1 in 2 women and 1 in 6 men over the age of 80 will develop an osteoporosis-related fracture in their lifetime. And I consider that that is a lot. Think that of all of us that are here today, half of us, after we are 50, are at risk of having an osteoporotic fracture. It is estimated that in the United States, 4.5 million of women over the age of 50 have osteoporosis, and another 22.5 million will have osteopenia. And osteopenia is a stage before osteoporosis. So the bone is starting to lose their calcium, but it's not as severe as osteoporosis. If there is a family history of osteoporosis, you are at a higher risk of developing it. And any prior fracture during a low-level injury also increases your risk of developing osteoporosis. Other risk factors include cigarette smoking, alcohol use, low intake of calcium and vitamin D, even during your teen years. And that's not something that we think about, right? But, you know, when in your 20s, the amount of calcium and vitamin D that you intake will have later on an effect about your risk of developing osteoporosis. Sedentary lifestyle also increases the risk. Certain medications, like in rheumatology, we use a lot of glucocorticoids or steroids to treat our arthritis flare-ups. So that increases the risk of developing osteoporosis. And certain breast cancer treatments, like aromatase inhibitors, certain prostate cancer treatments also increase the risk of osteoporosis. Other diseases, thyroid disease and other autoimmune disorders also increase the risk of developing osteoporosis. Next. So how is it diagnosed? How do we reach a diagnosis? And the gold standard is a bone density test, or what we call a DEXA scan. Every woman after 65 years old should have a bone density test to screen for it. We want to make a diagnosis early on before those bones break. And we should have a bone density test every 2 years. This is just a painless X-ray that measures the amount of bone in the hip and in the spine. This DEXA scan gives you a score, and this score is compared to the one of young, healthy people. And this is what we call a T-score. So if you look in the bottom of the slide, any T-scores of minus 2.5 or lower will make a diagnosis of osteoporosis. Anything between minus 0.1 and minus 2.5 will make a diagnosis of osteopenia. So that means that there is some bone loss, but it's not as bad yet. And anything lower than minus 1 is considered a normal value. Now, most of the patients who have osteoporosis are probably going to need some kind of medication treatment. And patients who have osteopenia, the treatment, if they qualify for treatment or not, is going to depend on the other risk factors of developing osteoporosis. So how do we treat? Again, the gold standard is to prevent further bone loss and to decrease the risk of fractures. So weight-bearing exercises are key. Adequate intake of vitamin D and calcium. We need somewhere between 400 to 800 units of vitamin D daily and somewhere between 1,000 and 15 milligrams of calcium daily. And in my next slide, I have another picture. And this is a picture, again, we have the osteoclasts that destroy bone that are in the right side and they are red, and the osteoblasts that make new bone and they are in the right side and they are in the blue. So we have the class of medications that we call antiresorptive medications that inhibit the activity of the osteoclast. So they don't continue to destroy the bone. The most common ones are Fosamax, and other biphosphonates. We also have another medication called Prolia that you may have heard of. And then we also have on the other side the ones that we call anabolic agents that stimulate bone formation. So what they are going to do is they are going to help those osteoblasts to make new bone. And there is 2 here currently in the United States, Forteo and Temlos. And then we also have a newer treatment called Evenity, which usually has both actions. It inhibits the osteoclast and it stimulates the osteoblast. So it has both actions at the same time. And that's all regarding osteoporosis. This is another picture of my family and I, and this is in the Jingle Bell Run on 2021, this past year, where again, we have plenty of fun. So if you have any questions, just write them down. We'll address them at the end of the talk. So I'm going to introduce to our next speaker, and she is Dr. Anna Escafianaki. And she's an OBGYN, and she's a specialist in maternal fetal medicine at the University of Miami.
Thank you so much. Can you hear me? Great. That is a hard act to follow. That's a great talk. And I really appreciated that refresher as well, because in my field, we don't see a lot of osteoporosis. So I practice maternal fetal medicine. And I have had some patients with osteoporosis, but rare, because those are usually a genetic difference that presents early. In maternal fetal medicine, we take care of pregnant people, and it is a subspecialty of OBGYN. So we do 4 years of OBGYN, and then we do our fellowship in maternal fetal medicine. And what's great about this field is that we really get to participate in some of the highs and lows of people's lives. And we get to work very closely with a lot of specialists. So when it comes to talking about arthritis in maternal fetal medicine, we mostly see the autoimmune types of arthritis and or arthritides, as we say in the textbooks. It is true that in the past we used to give very, very bad advice, like I think what Carol heard. But what I can tell you is that recently the news is pretty good. And we are able to really support people through pregnancies. And there's a few things that we really follow. So I don't have slides, but I will take you through usually what I do with a patient. Fortunately, the community of people who have arthritis, like yourselves, for some of you, are really proactive. And so I do end up seeing a lot of people for what we call preconception counseling. And that is probably one of my favorite things, because it means that people are planning pregnancies. And just as an aside, we know that 50% of pregnancies are not planned. That doesn't mean they're not wanted, it's just they're not planned. But when people are planning pregnancies, especially when they have some kind of other medical issue going on, we just see better outcomes. So the number one thing that I tell people with the autoimmune arthritis is that the disease activity at the time of conception tends to predict how you do during the pregnancy. And that's really something that we live by. And I will say that the most common things that we see are lupus and rheumatoid arthritis. Those are our most common. And so what we do is we work really closely with our rheumatologists to get people to what we call disease quiescence. And there are a lot of options now. Of course, the older medications, the sulfasalazines, the hydroxychloroquines, those are really, I would say, the crux of our management. But all the new TNF alpha inhibitors, there are some that are newer than others, and so we have more data. But we're really getting reassuring data in pregnancy as well. And at least one of them doesn't seem to cross the placenta too much either. So we tend to favor that one a little bit more. I have, especially in the last 10 years, had patients come in with medications that we have very little data on. And we have to make a decision, right? They come in and they say, hey, I'm thinking about pregnancy. This is the only medication that's worked for me. What should we do? And that's not so easy. So that's where I would say in maternal fetal medicine, we still get to practice a little bit of the art of medicine, because we get to take what we know from pharmacology and physiology and how pregnancy changes our physiology, what our livers and our kidneys and our volume changes in pregnancy. And we get to say, you know what, based on what I'm seeing from this molecule, I would predict X. And then we encourage everybody who's on a medication that's not well studied to enroll in a registry, right? So that we can get that type of data. And a lot of times there is a leap of faith in the sense that we know that people who have active disease don't tend to do as well in pregnancy. And so we try to continue what's worked. Within reason. There are some medications like methotrexate that we don't use in pregnancy. That's just proven bad. So in preparation for pregnancy, it's so much of what you've already heard, right? It's getting the disease under control, eating right. I would argue that even if you have no medical diagnoses, avoiding processed foods is kind of the way to go, right? Although in our culture, in our society, that's certainly not so easy to do. We also really want to understand what's going on systemically in the person, right? Some of these arthritis conditions affect the kidneys, affect the liver, affect other organ systems. And we do know, unfortunately, that if the kidney is involved, the outcomes for pregnancy are much worse. In pregnancy, we have seen in bigger studies that people who have some of these autoimmune arthritis conditions, the baby can be a little smaller, can be born a little ahead of time. And importantly for us, may have one of these hypertensive disorders. If people are familiar with preeclampsia, preeclampsia is a fascinating syndrome that has to do with how the placenta implants really early on in the uterus and the maternal reaction to that. And in people who have kidney disease or even underlying heart disease, things like that, something doesn't go right and that attachment doesn't work well. And the rest of the pregnancy is kind of compensating and reacting to that. And so, if I do have a person who comes in and has bad kidney disease, I might tell them that they're not the best candidate for pregnancy, which is hard to hear. And I will tell you that a lot of times I'm not really listened to because our drive to procreate and to be pregnant is very strong. So we talk about that. If we need to change medications, we change medications. There are some cases where mobility might be an issue, right? If the arthritis is already compromising how much people can move, even bread and butter, right? This is not brain surgery. How much can you flex your hips, right? Can you get into a birthing position? We've had people who can't. And so they have to have a cesarean. That's not the worst thing in the world to have a scheduled cesarean, but if we can, we almost always advocate for a vaginal birth. Like Dr. Ventimiglia said, we talk about other comorbidities. If there's diabetes or high blood pressure or something like that, we'll work on that. And then one little nuance that might be a little TMI is whether or not people have SSA or Ssb antibodies. So those are the antibodies associated with Sjogren's. And what's fascinating in our field is that these antibodies, the mom can have them and they can actually pass to the baby and settle in the heart and cause a disturbance in the electrical conduction. So the baby has a heart rate abnormality. It's very rare, but it is something that we think about. So then once we get all our ducks in a row and we have a good team, we do know that fertility seems to be somewhat reduced, especially in rheumatoid and in lupus. We're not totally sure why that is. That may be because people are pursuing pregnancy less. They don't feel well, or they've been told don't do this. They worry about passing things on to the baby, things like that. But overall, those issues with fertility can be overcome. And then when people are pregnant, we do a lot of co-management with our rheumatology friends. We monitor symptoms, we adjust medications. If people flare during pregnancy, we may do steroids. We use steroids very frequently in pregnancy, usually with good effect. There's usually more of an effect on the actual patient than on the baby, right? Because who wants to be on a lot of steroids? They don't make us feel good. They can mess with our mood and our sleep and things like that, and things which are already a little bit changed when we're pregnant. And we do watch on ultrasound, we watch fetal growth. If there is those SSA antibodies, we will look at and follow and see if there's any changes in a particular heart rate pattern. Exercise, right? Again, the same things that we've heard. Exercise, we very much advocate. In the olden days, right, they used to say, oh, no, you're pregnant, you're eating for 2, a total lie. And you should just sit for the whole pregnancy, a total lie. So we know very well that people who are able to be active in pregnancy have much better outcomes, as I like to say, from the neck down and from the neck up, because it really is a mood modifying agent there to be exercising. And the same with diet as well, right? A healthy diet decreases a whole host of complications in pregnancy, diabetes, things like that. There is data out there that suggests that people flare more postpartum, and that during pregnancy their disease can be a little bit more quiet. Recently, people are kind of challenging that, and maybe it's not everybody. Maybe it's like 60% of people do better in pregnancy and then they flare postpartum. But that's a lot of what we talk about with our rheumatologists in the co-management, right? So some people just may want to come off their meds, right? They know the data. We try to reassure them, but they say, I'm going to try off my meds. I'm going to do this, or I'm going to take my meds until the third trimester. Some of these TNF alpha modulators, there's this idea that they could affect the immune system of the baby. And so some people say come off of them so that the baby comes out unexposed. It could affect your vaccine dosing for the babies, things like that. But if we do that, then, day one postpartum, we're talking about putting people back on their medications, because it does seem that people tend to flare postpartum. And then we're just very careful about breastfeeding. We almost always promote breastfeeding if it's possible, but we have to look at the specific medication and what data is out there and what's available, really. Because again, a lot of these medications, it's a win for our patients, but there's just not a ton of data out there. So that's kind of like in a nutshell what we do in maternal fetal medicine. And I can tell you, even just anecdotally, overall, we have great outcomes. And I think that people who are well informed and have had the care throughout pregnancy really feel supported and really feel like this is something that is not an insurmountable obstacle. And then, pregnancy and labor and birth and breastfeeding for a lot of women are just really empowering experiences. We do have people who have not so great outcomes, and we follow that as much as we can, and we do what we can. But overall, we do well. So I think I'll leave it at that. And I'm seeing questions popping up. I think maybe we have time to open it up to the floor. You're muted, Carol.
I didn't know I was. Thank you.
There you go.
I wanted to say thank you to both of you. That was such helpful information, and I know everyone will take something away. To Dr. Ventimiglia, I was so interested to hear about osteoporosis. Many of us have been taking steroids on and off, for years in my case. And I saw bone loss for the first time, a few years ago after I was on prednisone for about a year and a half. So that was really fascinating to me. And I'm just going to call you Dr. Anna, if you don't mind.
That's okay.
I want to know, where in the world were you when I was pregnant? Was, you know so much about it. I feel like when I was pregnant, it was the dark ages. But wow, I learned a lot. And if I ever know anyone pregnant with RA, I'm sending them to you. That was really interesting. Anyway, now we're going to open it up to questions. You can use the chat function if you want to add another question, or you can come off of mute. We'll be looking, Mariel is going to help me recognize, but we're going to start with a couple of questions I already have. One is, and I'm going to let the two doctors to decide who's the best to answer it. How can arthritis react when you have other conditions like diabetes, high blood pressure, and hypothyroidism? That's probably you, Dr. Ventimiglia.
Yes. So, what I usually like to tell my patients is we look at to our body as a whole. And if you have other conditions that are not taken care of, that will make your arthritis flare up more and have more pain. You want to manage your weight, you want to manage your diabetes, you want to manage your high blood pressure, your thyroid disease. When something is not in equilibrium, it will affect your arthritis and it will make you have more pain. So it's a work in progress, and we want to address all of those conditions at the same time.
Thank you. I think this next one is for you too.
Okay.
Can you address the relationship of aromatase inhibitor induced osteoporosis in best treatment strategies to decrease progression? Also,
Yes.
is there a relationship between AI and onset of autoimmune diseases?
Okay, so aromatase inhibitors are medications that are given to patients who have had breast cancer because they prevent the recurrence of breast cancer. So unfortunately, these kind of medications, again, they interfere with our normal hormones and they increase the risk of osteoporosis. The treatment is not going to be any different than the treatment that osteoporosis will have. So the same thing as we had mentioned in the prior slides, if you follow in the range of osteoporosis, you will probably need some kind of medication. If you are in the osteopenic range and you have a risk factor, you might need treatment compared to if you don't have any other risk factors. And again, we want to have enough calcium, vitamin D, no alcohol, no tobacco use, and a good plan of exercises. Regarding the risk of aromatase inhibitors and autoimmune disorder, I did look at some data that suggests that patients who are taking these kind of medications, they could develop rheumatoid arthritis. And I don't think we exactly know as of why, but there are reports that rheumatoid arthritis is seen more patients who are taking that kind of medications have a higher incidence of rheumatoid arthritis, but I don't think we understand exactly as of why.
Thank you.
You're welcome.
Mariel, do we have more questions?
We do. Let's see. Landy asked, what are your thoughts on Meloxicam? And specifically, part of the question is, she wants to be sure it keeps working effectively, curious about long-term effect to increasing the dose.
So Meloxicam is what we will call an anti-inflammatory, and we use that to control the pain in patients with rheumatoid arthritis. Is a better option than taking prednisone. Long-term effects are kidney disease, and that is a side effect that we can have with all of the anti-inflammatories. Unfortunately, we will be checking on that. We do blood work every 3 months to make sure that the patient is not developing any problems. It also can increase the risk of stomach ulcers or gastritis. So if you have a history of stomach ulcers, it may not be a good idea to take Meloxicam. The doses, they start in 7.5 milligrams. The maximum that it can be taken in a day is 15 milligrams, no more than that. And, it's just basically, are there any risk factors for ulcers, gastritis? Is there any kidney disease? So that's something that your doctor will keep an eye on.
Okay, thank you. Robin asked Dr. Maria, what is the nexus between osteoporosis and osteoarthritis? What about negative side effects of the medications?
Okay, so I don't think there is a specific relationship between osteoarthritis and osteoporosis. Osteoarthritis is when the cushion in between the bones wears off. Now, if the patient has osteoarthritis, they can develop more bone, and the readings of the bone density test in the spine may not be accurate, so they may be falsely normal. Sometimes we consider doing the bone density test instead of measuring the spine and the hips, which is usually done. If the patient has a lot of osteoarthritis in their spine, we will do the hips and the wrist. We will avoid doing the spine. That's something to keep in mind. And then regarding treatment, so a lot of these medications, can you hear me?
Yes.
Yes.
A lot of these medications, unfortunately, can cause what we call osteonecrosis of the jaw, which is a specific problem with the bone in the jaw. And that usually happens in patients who have a lot of dental issues. So we want to kind of coordinate with that. If you are going to have some dental work done, then you don't want to be taking one of the treatments for the osteoporosis. Stomach upset is another one. So, we want to take the medication with a full glass of water. There is new options where you can get a shot once a year instead of taking a medication by mouth every week. Those are the most common things that we see.
Okay, thank you. We have a question for Dr. Anna. Do you generally recommend a preconception appointment with a specialist such as yourself for a person with autoimmune arthritis starting their pregnancy process? Due to my age, egg freezing has been discussed, but neither my rheumatologist or NP has said anything about preconception visits or maternal fetal specialists.
Yeah, so I actually just messaged as well, and there was another question up here about what advice can we give our daughters in their teens and 20s, and I feel like this is a little intertwined, and this is where I get a little bit on my soapbox because I think the generation of celebrities and women who are older make it seem like you're just going to have babies forever and there's no fertility clock and things like that. And that's a major disservice, I think, to women. And so I have, as a person who delayed childbearing, and, I feel it, I'm an old mom of young kids. It is very important that people, if they know they want to have kids and they are in a relationship, know that have them young. It's a terribly long-winded answer, and I say this with a grain of salt. And I know everybody's circumstance is different, but especially when I have people who have, well, which is most of my practice, other diagnoses, if you add age to the risks associated with that diagnosis, it really compounds them. As an example, if you have lupus and you're 22, you probably, hopefully, don't have a ton of kidney problems. If you're 32, just by definition, there is aging associated with that. Your risks of preeclampsia, your risks of growth problems, of placental disorders goes up. You talk about 42, and that's a completely different discussion, right? So I think that for people who have diagnoses, I would encourage them, as soon as they even start to think that, oh yeah, maybe now's a good time, let me do this, just do it, because your outcomes are just going to be better. And I'm not saying do it at 22. I'm saying do it at 26, at 28. I don't think that that's a controversially young time to have a baby. People may not feel like they're ready. I say this to residents all the time. They're like, what? I'm going to have a baby during residency? And I'm like, yes, have a baby during residency, because if you're ready to do it, and some people, don't have a partner, have more than one partner. I'm inclusive here, you will find that there's not really a good time socially ever to have a baby. You're too old, you're too young, you don't have money, you do have money, you're settled, you're not settled. But medically and obstetrically, there is a really good time to have a baby. And I would say that it is on the younger side. And I think if the corollary to this is, should you talk to a maternal fetal medicine specialist? That's the kind of info you're going to get from an MFM that you may not get from your GP or from somebody who doesn't, isn't used to saying it like we are. Just tell it like it is. And when I talk to med students like this, I'm always scared that they're going to write me up for telling them to have babies. But I give all my disclaimers as well. But that's really what I can say. And with an MFM, it doesn't mean that if you come see me, you have to get pregnant. You're just coming for info. And it's a lot of what we do. And clearly, as this group knows, information is strength. So that's my plug there.
Perfect. Well, we have time for just one more question. We're right at 7 o'clock. And that last question is, does rheumatoid arthritis change at all after menopause?
And to answer that question, I don't think that we know for sure. In my experience, I really have not seen that it becomes better or worse after menopause, even though there is the thought that hormones, have an impact on it. But if there is a risk factor, you want to start, like rheumatoid arthritis, it puts you a risk factor to have osteoporosis, then you probably are going to develop want to have a bone density test earlier than age 65. But other than that, in my clinical experience, I have not seen any specific changes after menopause.
Okay, thank you. Thank you to both speakers again, and thank you to everyone who took the time tonight to join us for this program. We hope you leave feeling a little more educated and empowered, and we encourage you to connect with us at the Arthritis Foundation after this program. The Arthritis Foundation is a volunteer-led organization, and volunteers are the heart of the organization. And it is through your support that we were able to fulfill our mission to expand our reach to those that need us the most, arthritis warriors and their families. If you might be interested in learning more about volunteer opportunities, please reach out to us, and we will put contact information in the chat. Thanks again, and have a great night, everyone.
Thank you.
Thank you. Thank you, everyone.
Thank you.